We're going to start. I was just about to say, and before we start, I want to make sure that everybody knows that we are going to be recording today's Director Speaker Series. So now you all know that, and recording has started. Jamie, I'll turn it over to you for the kickoff.
You got us a little started, so I'm just that we'll be recording. And we're really excited. As you all know, this is our second of our AHRQ Director Speaker Series. And again, the purpose of this speaker series is really to kind of challenge our own thinking here at AHRQ about the work we do to make sure that our work continues to be impactful and that we really are thinking about things, you know, outside of our current space. And so we're very excited about today. Obviously, many of you already know Mai from our NAC, but she has other roles too and has lots of skills and ideas about how we can all think about our current equity work. In terms of the chat, you know, we really do want you to ask questions here. This will continue to be an initial discussion between David and Mai, but if you can ask questions in the chat feature and make sure you select all participants, and I'll be managing those towards the end of the presentation. And just to let you all know that we'll also have these recordings available to just AHRQ staff to see these at a later time. So with that, I will turn it back over to you, David.
Thank you so much. And Josh, if we could take down the slide, I don't think we'll need that. It's really a pleasure to welcome the team at AHRQ to this Director Series. As Jamie let us know, that the reason I was excited to restart this was the opportunity to bring in innovative thinkers, people who could challenge us and challenge our thinking as we go about our work. So the goal here really is to learn, to question our assumptions, and then take that work back into our dialogue over time. So this is really the beginning of a discussion. And it is a profound honor to welcome Mai Pham, one of the most creative and innovative thinkers that I've had the pleasure of working with. For those who don't know, I would like to start with a little bit of an introduction. Dr. Pham herself is a general internist, so a physician, and a known health policy thinker and leader. She is, or was, the vice president for alignment solutions at Anthem, this nation's second largest health insurer. Prior to joining Anthem, she served as a federal official here at HHS as the Chief Innovation Officer at the Center for Medicare and Medicaid Services within CMMI, so the Innovation Center. She was the founding official, she was called the founding official, and I know her as the architect of the programs related to the accountable care organizations, as well as a leader in CMMI's early work in primary care. Prior to joining the federal government, she was co-director of research at the Center for Studying Health Systems Change. She's published extensively on payment policy and the intersection of health disparities, quality measurement, patient and provider behavior, as well as the market and how health systems work. She continues to work and serve our community, serving on numerous advisory boards, including, of course, AHRQ's National Advisory Council, but also the Maryland Primary Care Program, the National Business Group on Health. She is a member of the Board Executive Committee for Healthcare Transformation Task Force as well. And I apologize, Maya, I don't actually know whose healthcare transformation that was. She's a graduate of Harvard University. She received her medical training at Temple University and her master's of public health at Johns Hopkins, where she was also a Robert Wood Johnson Scholar. Josh, if you could get it so you pin the two of us, Maya and myself, maybe I have the wrong view. So yeah, that's great. So Mai, I like the long introduction because it shows how important in Washington, D.C. we think you are, and we really do appreciate you spending this time with us. But what I didn't talk about, and what your bio doesn't talk about, is that you're now the president, CEO, and founder of a new organization. And it's because of that work, and when you shared with me your new journey, undertaking, and the website, I was enraptured. I was so moved by what we were doing and what you were saying. I wanted you to come and share that with us. And at AHRQ, we are really now thinking about equity from the bottom up in a comprehensive way. And it's a really exciting time to be given the opportunity, not just to think, not just to count disparities, but to move beyond disparities and think about how do we really change America? And within HHS, how do we change American healthcare to do equity? Our thinking has started appropriately with the president's work on structural racism and a focus on racial and ethnic. But the president didn't stop there. He went further. And your work in understanding people with disabilities and a specific community within that, I think, can help us expand our framework for equity. And if that's okay, that's how I'd love to kick off our discussion today. But before I even start, is there anything you'd like to say?
No, you lead me where you want to go, and
Okay.
I'll push back.
I count on that. So we're talking, and the Center for Exceptional Care focuses on people with intellectual and developmental disabilities. And actually, I don't even know anymore, should we be saying people with IDD, or is that the best language these days to do this? But if you could just frame for us how health and healthcare are different for people living with intellectual and developmental disabilities, what it's like, why we should be thinking about that. Let's just start as that foundation and we'll build from there.
Sure. So I should have taken you up on your offer to just open by thanking you for the opportunity. My intellectual roots, of course, are at AHRQ. And so this is very much, it feels like coming home. So really appreciate the audience and the interest. The reason that I got into this work, and I'll explain why it feels to me like a natural extension of the last 20 years of my career, is that while I was doing all of those things in broader payment and care delivery transformation, I was also a mother. And our second son, Alexander, is 18 and autistic. And per your question about language, of course, you know, the advocacy community is not uniform in its opinions. It's not monolithic, but generally speaking, autistic people prefer to be referred to, it use person first language. So autistic people as opposed to someone with autism. But with IDD, it's the opposite. When you refer to that population, it's more the norm to say people with IDD. Anyway, we survived Alexander's first crisis when he was a sophomore in high school. And it was in the aftermath of that, right, coming out of that, that I realized in retrospect, wow, our pediatrician never offered us anything, not even the diagnosis. And even when we told him the diagnosis, no referrals for peer support or any counseling, no presaging of what we should expect to come as he developed. And then we had a very well-intended pediatric psychiatrist who misdiagnosed Alexander's skin picking for OCD rather than really driven by anxiety, gave him the right drug, wrong dose, wrong reasons, lost his trust, turned him off with medication for 2 years at a time when he really needed medication. And then it was not even the healthcare system that got us to the solution. It was an educator who had run the autism support program at a local independent school for 10 years. So she just really knew this substrate of adolescent boy on the spectrum who was getting her cognitive behavior therapy credentials, but really just explained to us. She knew the science, she knew the literature, she explained to us cognitively what was going on. She explained to him why he seemed to be paying such a high price for the talents that he had. And she coached not just us, but his school counselors and his CBT provider. And most importantly, she referred us to a much more evidence-based psychiatrist whose training explicitly included what to do for this population. And it was a remarkable introductory visit with him where he took 50 minutes to walk the kid and me through every single RCT trial ever done that involved adolescence and anxiety and autism. And by the end of the session, Alexander was open to taking medication. And we developed the beginnings of a team. It's hardly perfect, but it helped us survive COVID, which was a friggin' nightmare for many kids like this. So So, you know, what we experienced was a pale version of the reality for this population. While life expectancy has increased for people with IDD, and by that, you know, the population includes conditions like Down syndrome, fetal alcohol syndrome, even ADHD and learning disabilities, and I'll explain why IEC in particular includes those diagnoses in our population. It's a diverse population and life expectancy has increased, but still people die preventable premature deaths from accidents and suicide and medical complications that have nothing to do with biology, but really to do with how they interface with the healthcare system and what happens or doesn't happen. So in spring of this year, NEJM Catalyst published some research done at Jefferson Health showing that intellectual disability, so what we would call low IQ, it's the single strongest predictor of COVID infection. Think about that. And aside from age, the single strongest predictor of COVID death. Not heart disease, not lung disease, intellectual disability, not driven by biology, right? And then when you look at the intersection of IDD with race, ethnicity, poverty, living in a rural area, things become truly horrific in all the expected directions. And so, you know, when I was able to take a breath from our own journey and learned all of this through a lot of exploration, I thought, wow, you know, there are two aspects to my woke moment. One, I was Medicare's chief innovation officer, and I didn't know this. It was in my house. But the other half of the woke movement was, I'm pretty sure this makes me typical of general healthcare leadership. And we have all of these strategies and wisdom from other domains in healthcare that we've never invested in bringing to this space to serve this population. So that was the genesis, David, and why I think there's opportunity here, not just for IEC, but for anyone interested in improving population health generally. I'm sure you'll ask other questions, but one framing that really helps me link it to all of my other healthcare work, which I continue to do, is that I am convinced of the universalism principle, that if you can design a system that serves the most vulnerable patients well, you will have designed a system that serves everyone better, right? So just a little bit of propaganda. Think about curb cutouts, designed for people in wheelchairs, but then once you have them, also terrific for parents with strollers, it turns out, and the elderly walking with canes, and people with luggage, which once upon a time, you all did, carried around luggage. And similarly, you know, in the healthcare arena, plain language. If you write health information at the 6th grade reading level, the people you help the most are actually 12th grade level readers, whom you mistakenly thought wanted to have it hard. And they didn't. They wanted to have it easier. So that's, you know, that gives you a sense of the why, I hope.
I have so many places I want to go with that, so thank you. And I'll just, because you're probably getting cheers that you can't hear, this is Health Literacy Awareness Month, so you just put in a plug, and we are very much with you on that. Though I would add, it's not talking to people with a 6th grade reading level with 6th grade ideas.
That's right.
It's about how to explain complex things simply and give people the information to make choices. I'd go a little further and also say, I think well, maybe later I'll push you a little bit on this. I actually no longer believe in universalism as a principle for how we do things. And I think you've given us part of the reason here is because people have different needs. So we need universal goals of what everybody should receive. But the way we do that has to be targeted at times to meet different populations' needs. And if we assume everybody gets it the same way, we end up, I think, sometimes missing marginalized and sometimes not even small populations. So how do we do both is going to be a question. So, okay.
I would push
Come
back
back.
and say,
Yes,
I would push
come
back
back.
and say that there is no inconsistency in my mind to person-centered services and supports and universalism, right? So I'll give you an example. One of our supporters is the family that started a specialized school for their Down syndrome son because the public schools wouldn't accept him. And that school is very focused on tailoring education to all of its students. And guess what happened? There are way more neurotypical families on the wait list than there are families with kids with IDD, right? Because the DNA to tailor your services is attractive to everyone. That's why I don't think there's an inconsistency.
I agree, but I think what you've done there is say the universal principle is that care must be individualized, must be patient-centered, and that patient-centered care or patient-centered or person-centered education systems that are tailored to the individual's needs are what should be the universal goals. But how we do that for a family with a teenager with autism might have to be different than how we do that for a family with a child with mobility disability. Or, and maybe we should get into this because you in your statistics, you started that your family with, you know, two exceptionally educated parents supporting their a teenager with autism might need different services than a single mom with less education who herself is dealing with trauma of her own, and how she is able to receive family-centered care for her child. That the system has to be able to respond to both of your needs, but it won't be in the same way. Is that?
That's right. That said, there are that entire range of variation in needs requires certain transformations in the system that are universal. Right, like we need to fix financing and payment for all of it. We need quality measurement rubrics for all of it. We need a much better prepared general clinical workforce for all of it. So I think that there are, you know, and part of that preparedness you want to train the workforce in is the whole mindset of tailoring care and being very focused on you know, a person's goals, not just their health goals, but what they want to do in life with good health, without judgment, you know. And this is I think it has so many nuances in so many different directions, because, for example, again, I don't want to paint whole populations with a single brush, but you know, some racial ethnic groups just philosophically feel different about IDD than you know, majority white America. In some cultures, it's not a shame. It's how God made the child, and you're going to go with it. And so their threshold for seeking help is different than some other families, and the kinds of help they would want are different. I can tell you, traditional Asian families are very reticent culturally about having strangers come into, not strangers, but people not in their family, be in their home. So now imagine a patient who really needs a direct support person, right? Who happens to be Asian and dependent on older Asian parents. There are nuances in every direction, but you don't ask the right questions unless you're worried about it.
So I'll just put in the plug for When Spirit Catches You, You Fall Down, as one of the best, for me, a transformative book on cross-cultural understanding of health and healthcare, which I think you're building on in a slightly different way. But I want to take us back, because I think for the audience, you've already moved beyond. There are stigma here. This is a healthcare issue that we need to destigmatize. And so if you could share a little bit more about how you see the typical US culture, and specifically healthcare and healthcare professionals approaching people with IDD. Love to hear your thoughts on that.
Yes. So I will start with my framing about this, and then I'll point you to some previous research. There's been a lot of research. So I find that within general healthcare, there tends to be certain bear traps that we fall into, certain assumptions we make about this population that are either outdated or not informed. One is that it's a small population, right? That it's a niche somehow. The way the CDC and the latest survey research, which by the way was 1995, counts it, when we extrapolate to 2020 population numbers, it's somewhere between 10 and 16 million. So 3 to 5% of the population with IDD. Now, the 16 million is if you include ADHD and learning disabilities, and we can argue about that. But there's a lot of misclassification with those labels as well. So it's not a niche. In fact, if I asked this audience to raise your hand if you don't know anyone or any family that's affected with IDD, that would be an interesting poll to take. I've rarely been in rooms where the majority of hands went up there. So that's one bear trap. Another bear trap is that they have lower quality of life and life expectancy is very short, like on the order of 30, 40 years. It's actually 70 years. And so the healthcare implication is they accrue physical and mental health conditions just like the rest of us. Down syndrome and dementia didn't used to be a thing. And now it's such a thing that AARP is having to think about it, right? And so, this niche thing, this they don't live very long thing, it makes it convenient to not have IDD be a problem that general healthcare needs to think about, when in fact it does. In addition to which, there are all kinds of implications for the health of caregivers. So family caregivers in particular, for people with IDD, suffer combat level stress, much higher rates of all kinds of mental health conditions, and work productivity losses, and divorce, right? We don't think about that. I think another kind of bear trap is it's not our problem, that there's some set of specialized clinicians out there whose job it is to take care of this population. You can take a center of excellence approach to cystic fibrosis, because what do you have? 30,000 cases a year, okay, versus 10 to 16 million. That's not viable as a center of excellence approach. So all of these things pile up. And the negative bias toward people with disabilities is particularly noticeable in healthcare. In the broader culture, we're beginning to see some normalization of IDD, right? You've got Elon Musk coming out as being autistic, and you've got movies like Crip Camp and TV shows like Atypical or Love on the Spectrum. They may not be perfect depictions, nothing ever is, especially early in a cultural transformation, but it's in the air. Within healthcare, Lisa Iazzoni published in Health Affairs earlier this year, it was just confirmatory of all the literature that has gone before it, that over 80% of physicians are convinced that people with disabilities generally have lower quality of life. So think about the implications of that for decisions around resource allocation, or your threshold for getting a DNA, or how hard you try generally in your relationship with this patient or their family. Within disability, and this was not in Lisa's paper, but previous research, there's a hierarchy. People who are blind and who have physical disabilities actually tend to generate somewhat more positive reactions from healthcare providers. People who are deaf and have IDD are way at the bottom. So it's layers of stigma and negative bias. We try to call them cultural challenges, but it becomes an issue when it comes to training, because I get into these infinite loops with clinical educators and policymakers in that arena where they say, I can get you the audience, but you're not going to keep them unless you do culture change first. It doesn't matter what the curricular requirements are. To which I say, you need to get them in the seats before I can do culture change, right? And so we understand that, but that is the work that needs to be done, even among sophisticated health policymakers. Once again, I was CMS's innovation officer, and it was right in front of me, and I didn't understand. I didn't think it was important to understand. Part of the reason is because this population is relatively invisible in healthcare data. You think about how poorly depression was coded back in the 1990s, early 90s, 80s. It's worse for IDD. So there isn't a ton of published data on this, but our initial data pulls from commercial claims, from EMRs, you capture on the order of 10% of the expected prevalence for adults and about 25% for kids. Well, of course, then it's not important to healthcare executives. They can't see the people, but it doesn't mean that people aren't there. They may well be lurking in your high cost, high need group. They may well be lurking in your preventable ED visits, in your behavioral health, in your complex populations. You can't take care of the problem because you're not addressing the root causes. So that's a long winding answer, David.
Well, that was an amazing set of issues. And unfortunately, too many for us to unpack all of them. And I am going to force myself to try to prioritize. But just to quickly summarize, you pointed out the population, not of just disabled people, which is probably is even larger, but within disability, IDD is much more prevalent than we recognize as a country and as within healthcare. That we, as a healthcare system and the providers in it, have a tendency to underestimate the lifespan and therefore devalue the people. And so preventive services or working harder or crisis of care things, we may be making poor decisions. That we don't train the large system of people that interact, because there are a lot of people. So we don't have a health system designed to support the knowledge and the skills and the resources that people need. And that these people are part of communities and part of families, and we don't have a healthcare system that is caring for the whole family or recognizing these, let alone those other cultural issues. So we said, and then you pointed out, to fix this, we need transformation, we need policy, we need payment changes, we need training changes. And I would love to hear more about that. But since I'm going to turn it over to my colleagues before I let you go, I want to ask, since you know AHRQ, and thank you for seeing us as your home, because we love that, or I love that. Where do you think you would prioritize AHRQ helping move this transformation forward? Recognizing we do we fund health services research, we help with practice change, and we collect data. So I think you've touched on all of them, but I'd love to give you the platform to say, given all that needs to be done, where would you have AHRQ start and prioritize?
Thank you for that. And I apologize if it sounds self-serving, because we're trying to work on several of these dimensions of system change. But the reason is because we think it's important. So I think AHRQ could play a pivotal role in a way that I don't think is in the DNA of NIH, for example. To think about how to fix the data, how to create proxies that don't rely on clinician coding, so that we can actually find this population. And the finding of the population is, and our particular approach to it is to think about using artificial intelligence and big data. This is a commodity skill set now, right? It shouldn't be hard to do. It's a matter of will and getting a large enough population of true negative and true positive cases for machines to learn. The reason it's important to do that is that is foundational. That then opens up a whole world of research. I would argue that we can't trust a good chunk of the current literature on IDD. We don't really know what the cost, utilization and outcomes matrix is, because we've been working with pretty funky numerators and denominators for decades. We may need to refresh the entire literature. And then there's all kinds of other interesting research to be done. I think there's tremendous variation in both how people are seen, how they are cared for, that has not been adequately captured. So, I'll just give you a snippet, again, preliminary data, but when we look across states, the prevalence rates for IDD varies wildly, depending on whether you include ADHD and learning disabilities or not. So in southern states in general, very high rates of ADHD and learning disabilities, very low rates of autism. The opposite in Minnesota or California or New York, right? Surely that's not driven by biology. And AHRQ has an allergy to variation. So I think that supporting the investigations there and asking the hard questions there, that's another whole arena of opportunity. I do think that performance measurement, and David and I were starting to debate this in the preamble to the session, that in general, I am skeptical of the measurement industrial complex. I think we chase false precision. I think we've created way too much burden. And at the end of the day, most guideline-driven metrics, as NCQA will quietly confess to you, don't actually link to outcomes. And so, especially for a population where, frankly, there aren't that many clinical guidelines that are relevant. There's no clinical guideline for quality of life or for functional status. That's not going to happen. It shouldn't happen. It should be person-centered, which means we need to seriously get scientific about person-centered performance metrics, and develop enough of a repertoire that where we're not after extreme precision. And I know the gravitational pull of providers who say, but you need to risk adjust and my patients are different. And yeah, but we also need to measure what's meaningful to them. And we know that most of your practices are texting them right after the visit to ask how satisfied they were. So we know that there are lots of arenas where you're not so wedded to precision. So give it up. Right, that's a whole arena of opportunity. And then I think from there, it really is about improving services and what models of care work. In particular, I would point to several things. One is, the intake process, when, age at diagnosis and how initial supports get set up. Then transitioning to adulthood is a dicey time for anyone with complex needs. For this population, it's a complete nightmare because they fall off a benefits cliff, right? In terms of disability and insurance benefits, as well as they have to somehow get their information from here to there, and find adult care clinicians who are trained to serve them, which don't exist. And then I would say within services and supports, man, that coordination piece, while I know we're still working on solving it within healthcare's four walls, the interface between clinical domains and home and community-based services is a particularly fraught one. There are care models out there. We're trying to answer the question, what should healthcare's role be in that coordination relationship? And I got to tell you, the early input we're getting from stakeholders in the disability community is healthcare should have zero to very little role. Just share us the data, shut up, get out of the way. You know why? Because the mistrust is so deep that they have given up on general healthcare. They now see general healthcare purely as a source of harm. So give me as little exposure to that as possible. you know, and I think we can get over that, but I'm exaggerating a little bit for effect, but I want you to have the sense of the kind of bridge building that needs to be done. So to the extent that AHRQ also sees it within its purview to facilitate that kind of bridge building, I think that's also really important because it's in both directions, right? The disability community has not wanted to really understand, for example, how a health plan actuary thinks. Right? Or the limits of what clinical practices can do. Those are some starter ideas. I'll give you more to do next.
So Jamie, thank you for rejoining us. I have more questions, but if I'm going to ask you, Jamie, if our team has started to post.
No, I was just going to say this. I was just going to tell folks to just start populating your questions in the chat, and we'll turn to those folks in a couple minutes. So.
So what's your vision or IEC's vision of what a transformed healthcare system would look like for people with IDD or for all of us?
Yeah, I think it looks like a system where the care is solid enough and predictable enough that families can stop what I call forever seeking, right? Where you feel like there's no door you walk through where your problem actually gets solved and they feel safe. And people with IDD can thrive to the best of their ability. I think that requires a much more systematically trained workforce that is clinically and culturally competent. I think to get there, and this is why we bootstrap our work across several domains, we have to be smarter about financing and payment. This is not a population that fee-for-service will ever do well by. Despite what some advocates cling to because they're so paranoid that benefits will be taken away under capitation. And we need to get more creative about financing. When a person's well-being is so reliant on true synthesis and coordination of clinical and non-clinical services, as this population is, it's fakaka that those two systems are financed completely separately. And even when you give a Medicaid managed care plan the bucket of dollars for this population to cover both home community-based services and clinical, how do you price that? There is no risk stratification method that takes into account both buckets. And by the way, you can't just do A plus B because there are interactions between the two, right? What happens to that person's diabetes or COPD has not a little bit to do with whether they're getting direct support services at home. So it's not A plus B. We haven't figured out that science either. So there's that piece of it. And then that coordination piece has to be deliberate, those connections, as IEC would say. It can't be wave your hand and good intention, or things, on paper. It needs to be practice. We need to actually exercise within established processes, have clear roles and responsibilities and standards for that. And then I think culturally, we need to think about how we build in those universalism components so that the general healthcare system sees the benefits for itself, the ancillary benefits of doing well by this population. If you're an ACO and you're worried about your high cost, high need, might help you figure out why that person keeps showing up in the ED if you could determine whether or not they had IDD. Right. So there are, I think there's a multitude of opportunities here. The vision is in some ways very straightforward. Be committed, be prepared, and invest in it.
Jamie, I'm looking at the top because if not,
Yeah.
I'm going to jump in.
No. So I would just say, hang on one second. And I would say, I think we're hearing some stuff in the chat about like, just, wow, thank you. I mean, I think you're highlighting so many important things that many of us, it's humbling in many ways that we haven't really been thinking about. But so I just wanted to take this opportunity to say thank you for some of the NAC members who also joined us to listen to this. And I'll take the first comment from Chris Goschel, who's on our NAC, but her comment, and again, as when I think about what the work that we do at AHRQ, we often frame ourselves as folks who help healthcare delivery systems, improve care for patients. And Chris's comment is, I wonder what individuals who are in the care delivery, in care delivery and implementation research realms can do, and what should we be reading to become more educated about this?
Sure, thank you for the question, Chris. My go-to source for many academic things is the American Academy on IDD. Maggie Nygren is the executive director. They're a great place to start. Then there are, university centers on disability, USEDs they're called, that are federally funded. They each have a different focus, and it's not always IDD. It's a broader disability lens, but they churn out a whole bunch of research. And then, depending on how wonky you want to get, like we can go offline. For example, if you wanted to learn everything about how Medicaid agencies set their IDD budgets and long-term service support budgets, I would send you to the Human Services Research Institute or others. But there are also many clinical centers that well, where there are bright spots of both research and clinical innovation going on. I would point to Brian Scottco at Mass General, who runs the Down syndrome clinic there, motivated by his sister with Down syndrome, who's done some spectacular research and innovation around making their really comprehensive team-based services digital and accessible to people in many other states. So, and they're community-based innovators as well. So that could be a very long list, Chris, but happy to give you some places to start.
We'll share them with the whole AHRQ team, because, well, I think Chris is just the canary there. There are a lot more. Mm-hmm. Jamie, are there more?
Yeah, so
sitting on my hands.
Okay, we'll get your chance in a second, but so the next question is, what can be done to improve mental health services for people with IDD? The comment was, I've seen a tendency to try to medicate people into submission rather than trying more behaviorally focused approaches.
Yeah, thank you for that question. So this is one of the biggest sources of mistrust that the disability community has with general health care. There are still some emergency departments where it's actual written policy to sedate a patient with IDD before you do anything else, before you even start asking about a history. Over medicalization is a real problem. And I think, it's not that medications can't be helpful. They're certainly helpful for my son, but in many instances, the mental health challenges are triggered by something that may be reversible or addressable, right? It may be a learning situation, a living situation. It may be, loss of a job. Now, healthcare can't fix all those things, but this is where the connections with home and community-based services become so critically important, because we are left in healthcare cleaning up messes that could be prevented if that person were better connected to home and community-based supports, whether that be for peer support to prevent social isolation, or coaching, or even job placement. There are lots of programs available to do that. And I think, the other thing is, while you may need different communication strategies to engage with patients with IDD, it is doable. And it's really important to understand what they want in terms of help. And to think about them as a whole person, especially, young adults who are struggling with all the same issues that all young adults struggle with: identity and sexuality, and those things that we often think are messy and don't want to get into.
Jamie, before we go on with the team, I wanted to just build for a moment. We've been using IDD as a microcosm, important in itself, but also to show as part of our larger thinking about equity. And so IDD as part of disability, and then a part of the whole healthcare systems issue of racial and ethnic disparities, gender disparities, gender identity disparities. It's all part of that. Have you found a framework that you think works well for government specifically, but healthcare more broadly, for approaching these issues of moving towards equity?
I think, again, I go back to the universalism point, because to my mind, inequities creep in because, and sometimes it's because we're not applying a one size fits all, but really, I think that's the wrong way to couch, say, racial disparities. Some group is not getting as much as some other group. Really what's happening is that some group is not getting what it needs and some other group is. Right? For me, that's the framing. And so it's bringing a certain humility to understanding what different populations and different people need, and then going from there, rather than looking for an equation, which tends to get you into bean counting services, bean counting process, whatever. That's not the point, right? Because what may underlie racial disparities, for example, in early diagnosis of autism is what I said before. Culturally, there's a higher threshold. It means you need to ask the question differently, maybe. Or you need to offer that family a different incentive for learning about the diagnosis. Anyway, that's my thought on that.
So a beautiful comment on that. What I heard is also that our goal, and I think this is the shift, I want my team to hear this, from disparities focus to equity focus, and you're moving beyond that universalist focus is, what do we all need to thrive? And the question is, who's getting it? And all of us, none of us are getting as much as we need. And how do we move more people closer to that goal? And then you were asking the question, why is this group, why is this person not achieving it and getting them the services they need to move towards that universal goal? It's not that we want everybody to be equal. We want everybody to get what's good. There are a lot of times where we have disparities, but even the majority group here in IGD as an example aren't doing as well.
Yeah.
So Jamie, back to you. Sorry.
No, one more comment here. How do we work towards adjusting the physical work environment? For example, understaffed teams might focus on Band-Aid treatments to just stabilize current immediate conditions and discharge patients that may contribute to the culture of ignoring or not considering IDD. And then she writes, sorry, I've seen and experienced moments where the healthcare team doesn't have the patience to be holistic, but also recognize that tasks and the working conditions contribute to that.
Yeah. So I think I have two veins of responses to that. One is, to the extent that this is about strapped teams, it is where the conversation on financing and payment come in. If you had the revenue flexibility of a population-based payment rather than your fee-for-service hamster wheel, you'd be slightly less stressed about that. It doesn't solve everything. The second piece is there are actually design elements that would take the temperature down for both patients, caregivers, and the providers. So really simple things like being conscious of what's on your ceiling, and having that be something that is soothing rather than not insisting on a TV blaring in the waiting room, right? Having exam rooms that everyone can step up on, offering a weighted blanket, which can be very reassuring, especially to patients who have less verbal ability and don't really understand what's going on. Learning about therapeutic options like inhaled Versed for people who are afraid of needles. Again, once you start looking for these opportunities and you start populating your practice environment, you're like, oh my God, why didn't I think of this? I would love to be offered inhaled Versed for myself, right? There's a long list of, you can call them accommodations. I think of them as just better design. that would serve everyone better. You know, an exam table that was adjustable in terms of height is ergonomically better for the clinician. I'm just saying.
So much I want to say. So Jamie, come on, next question. You're on mute.
Sorry about that. No, I say this next question is aligned with, you know, kind of what you're just saying, but there seems like there are so many opportunities for better communication with people, their caregivers and families, you know, and there's so many challenges there, and we have a need for training, cultural change and ways to capture data. You know, how do we get the system to start recognizing these challenges and invest in that?
Yeah. So we, you know, I learned the hard way at CMI that to make transformative change, you have to do it up here and you have to do it down here. You can't just do one or the other. So at the up here level, tomorrow morning, we are kicking off an action collaborative. It's called ABC Cubed, Action to Build Clinical Culture and Confidence, that will try to bring together organizations with the policy and programmatic platforms to take change to scale. So IEC doesn't need to create more curriculum materials. There is an endless supply of curriculum materials. They are sitting on a shelf because the demand isn't there. We want to create the demand. So we're bringing AAMC and the accrediting bodies and the medical societies together with disability organizations and groups that have experience, not just training clinicians, but then supporting them, right? It's one thing to sit through a training. It's another thing to actually put it into practice and feel like you're not being thrown in the deep end. But there is an echo autism. There is an echo IDD. There, you know, there are, we would love to invest in, you know, some national resource center where clinicians can actually call with case scenarios, you know, like ginormous echo, if you will, not just, you know, community specific. And so that's one level of change. The other is giving people the tools on the ground. So, and showing, engaging their leadership to set that expectation. So we're hoping to start a project in Long Island, for example, where we're going to take what we're learning now about what healthcare's role should be in coordinating with home and community-based services. And we're going to bring together a stakeholder coalition across all of Long Island, the major health systems, the community practices, the disability organizations, affected people, their caregivers. And we're going to say the ED is a pain point for everyone. That is super clear, don't need to take a vote. How do we solve having ED experiences be safe for patients, as well as getting them transitioned back to the community in a timely way with good outcomes, right? So it's both preventing the ED visits, making that encounter safe, and well, you can imagine the work streams that you need to stand up, right? That's a lot of cultural training. That's a lot of process improvement. That's perhaps IT, you know, change requests that you have to put in so that you can find the appropriate community-based organization to refer someone to. But we're doing it because we've got the chief quality officer from Northwell on board, and we've got there. Once people are invested and they understand that you're also trying to help them solve their pain, you know, I mean, ED births are worth millions of dollars right now, and they're clogged, and clinicians, no clinician actually wants to do harm, and they know that their patients are suffering in the EDs. They just want to solve the problem. They just don't know how. And so you bring them the tools. It's not that it'll be a snap, but there are known approaches, right? Did you know that there's an actual company called Station MD? It's a private practice group of emergency medicine docs, some of whom have affected children, who were appalled at their physical ED experiences. And so they created a completely virtual urgent and emergent care service just for people with IDD. They prevent 88% of those cases from actually ending up in a physical ED. And then inevitably what they do is they end up coaching the clinicians who refer the patients and the clinicians who receive the patients back. So there's culture change going on in all kinds of ways. We just need to marry the up here with the down here.
So there's one more question left. I think we still have time for one more. David, unless you want to.
No, please.
Okay. The last one, you mentioned a benefits cliff that individuals with disabilities can transition between childhood to young adulthood. But they probably face a big transition beyond depending on parents to advocate for an individual's needs, medical and non-medical. Is there evidence for care managers or other professionals to take over that role? And how does that healthcare system support this or not?
Yeah, right. There's a lot of conversation, or has been a lot of conversation, about supported decision-making rather than custodial options. And I think that is definitely the path the advocacy community would favor. So in those circumstances, it's really up to the patient whom they would want in the room and trust enough to have that kind of a relationship with. So I see no reason that, a strong healthcare relationship would be ruled out. I think if you have a really good foundation with that patient and they trust you, I don't see why you couldn't play that role for them. Could there be some conflicts of interest potentially, but then there could be a third person as well. So there's several different configurations for supportive decision-making that are worth investigating. I agree with you. All of those, certainly for me as a parent, those are the palpitations, is what happens when I'm gone. Right?
Yeah. Well, on behalf of the agency and myself, I want to thank you for taking the time to start us on this journey. And
David, can I just, I see one more question that I don't want to let go. It's just about how AHRQ might engage with individuals with IDD and their caregivers as part of your efforts. And what I would say is just have them on everything. There's not a single project we do that doesn't include an affected person and or a caregiver paid in some role, either on the team, as a reviewer, as an advisor. Just do it. Make it a reflex.
Oh, I'm going to have a follow-up conversation with you on that, because I think one of our challenges at AHRQ is that we're asked to have somebody with mental health issues, substance abuse issues, families with IDD, dementia care, diabetes, sickle cell. We can't be, we need another model. We can't have all of those folks. And in fact, they don't always represent each other. And so how to bring the patient voice. Now, I think it's really important for projects related to this. We obviously and in fact, for the team and for you and for our NAC members to know, we're actually going to start a process of having patient and patient advocates and representatives, family, community members on our study sections to just begin that really important work of culture change, to fund research that's more relevant. But even that is going to take work, but we're committed to doing it. So you're starting, I hope, to see the thank yous roll in. But on behalf of all of us, for taking the time, for starting with us, I hope you will follow up with us and share some of those resources that you mentioned to Chris. Happy to share them with the rest of the team. For the folks at AHRQ who were able to find time today to join us, please tell your colleagues if this was helpful for you, because we, as Jamie said, we're going to make this available on the website for more of us to see it. And I hope we'll be able to invite you back and hear more about what's happening with your work, but share what we're doing and take this to a deeper level.
Thanks so much, David. It was a real pleasure.
Thank you. Be well, everybody.